Next, we're going to move into the live TAVR case transmission. If I could invite Dr. Chung, Dr. Berkey, Dr. Generu, Dr. DeMeo to come up to the top.
Yeah, we can do a Thor. Okay.
And we'll cut over to the
All right.
operating room of St. Francis. Hey, guys. Can you hear us? Or...
Hi. Yeah, we can hear you. Can you hear us?
Can you hear us?
Yes, we can. Yes.
All right. Well, no, thanks everybody for rejoining us. Dr. Khan and Dr. Petrosian and myself enjoyed our Concorde flight back to the USA, back to the hostile environment. So here we are back at Roslyn. And we're doing a transfemoral aortic valve replacement. Do we have the slides for the presentation?
We can see them.
Put the Iron Man down from here.
Yeah. Okay. Next slide. So this is a 91-year-old male with hypertension, hyperlipidemia, his coronary artery disease, status post-CABG in 1992, and subsequent PCIs, AVR NRT ablation in 2016. And of note, he is a very, very healthy 91-year-old, plays tennis every day, does push-ups every day, but he noticed that he's becoming increasingly shorter breath with exertion. Next slide. So he's had progressive shortness of breath, even at rest, for 3 days. Your Heart Association class 3 or 4. Next slide. On TEE, Len, can you, if Len's, well, Len's not with us. All right, so on TEE, with EF is 60 to 65%, aortic valve, there was severe aortic stenosis, peak velocity of 403. The mean systolic gradient was 38. The valve area by velocity time integral method was 0.8. There is moderate to severe 3+ mitral regurgitation directed eccentrically. Next slide. A cardiac cath, he had occlusion of native LAD with patent lima of the LAD and saphenous vein diagonal graft. The left main had patent stents, 50% mid circumflex lesion with occluded saphenous vein graft to the circumflex, and the right coronary is normal. Next slide. CTA, let's see the next slide. So Omar, you care to comment on this?
Sure. So it looks like the annular area is 450 and the perimeter 76. So for a sapien, I guess that falls into 26. And for a Corval, probably 29 for the Evolute. Sinuses are pretty large, above 30. And on the kind of 3 to 4 o'clock of the annulus, you see an area of calcification. And then up at the root, you see something, but it's possible that those are the stents that were described.
Yeah, so I think one of the issues in this case is that eccentric calcification at 3 or 4 o'clock. George, you have any comments about that?
Yeah, just that it's definitely a high risk feature. When you add that in along with his age, we're going to err on the side of being conservative, I think, with any balloon dilatation. So that one of the advantages of the self-expanding valve is that we can deploy it and not have any real trauma to the annulus. If we have aortic insufficiency, we'll have to pick a balloon on the conservative side. So the measurements that are shown there are a minimal diameter of about 21 and a maximal diameter of about 27. So I would err on the side if we have to post dilate with a 20 or 21 initially, just to play it safe.
Okay, next slide.
As opposed to what we typically would do would be go with the average size. So we typically would just balloon it with a 24.
So I think you can see more of the same in this view. Next slide. So the sinus heights are good. the coronary, the left main heavily calcified. Next slide. It's a sort of an up and down aorta. So the approach is good. There are intact vein grafts that you can see in the ascending aorta. Next slide. Calcification is moderate. So that's in keeping with our plan not to predilate. Next slide. And the access is good from the what we're showing on this slide. The right side, however, at the table side ultrasound. I mean, Jeffrey, you want to comment on that?
Just felt a bit nodular, and there was a small hematoma on the ultrasound. Also, not appreciable on the CT, but there was a bit of anterior calcium at that site. So we just used ultrasound to guide away from that calcium for the contralateral puncture, and going with the big sheath on this side. Ultrasound away.
All right, so you want to comment on the value of ultrasound and vascular access?
Yeah, wet one, please. Yeah, it gives you real-time guidance. You can make a nice anterior puncture. It's quick, it's reliable, it's safe. I really like it.
Next slide. Next slide. So in summary, we're thinking transfemoral approach. The mean diameters are 6.8 on both sides. We have now decided to go on the left side. That's it. So transfemoral aortic valve replacement. Next slide. Okay, let's go to the full screen now, images of what we're doing, because as I've been speaking, a lots have been accomplished.
The table's going
George.
on. Delberg.
No, I leveled it.
Oh, okay.
Yeah, it wasn't level before.
Oh, okay.
Yeah.
Gotcha.
Can you give us the full split screen? So, see, obviously on this one, you cut the surgeon out of the picture.
Always a good day.
Right. Second.
You bring this
pigtail,
camera
please.
in.
So
Okay.
on the groin here, we have, do you want to show everyone the access, what we've got?
All right, let's pan in on the access in the groin.
You want to roll
From the wall camera.
Todd, do you want to roll forward?
Come on in now, pan over. So we're going up
Good.
on the left side.
So what we've also put a sheath in the right radial artery that we're going to put a sentinel device in. That sheath is in, and we have sheaths in the right femoral artery and femoral vein. The femoral artery sheath on the right we're using for pigtail catheter that we'll use to inject during the procedure to show us the level of the valve implant. We always used
Roll it
to
forward.
put a temporary pacemaker in on the femoral vein and have it for two reasons. One, to rapid pace for balloon inflations, and also in case there's heart block. Lately, on selected cases, we've been pacing off the wire that we have in the left ventricle for the TAVR deployment. So we'll be doing that here. Do you have the alligator? Okay.
Ready to inject for 10.
Okay.
That looks good.
So we're gonna
Give the heparin.
And then sentinel.
put a large sheath in now on the left that we'll use to dilate the tract, and then we'll put our sentinel protection in and then go across the valve.
So one thing I want to point out is that in real time, we've actually been working about 15 minutes. When we first started doing TAVRs, so I want to introduce as well Chris Mullen and Dustin Garavelli. They are the representatives for Medtronic in this case. So Dustin, when we first started doing TAVR to get to this point, how long did it take?
Let's put a JR on that, please. Sentinel.
So he said 3 hours and a lot more people in the room.
Okay. Yeah, the Sentinel. Good.
Okay.
So now we're placing this from the radial artery on the right.
And I'm putting a catheter up on the left for crossing the valve. We have the straight wire.
The nice thing about having a left-handed surgeon is you can work simultaneously.
He's talking about me.
Yeah.
You have your own camera now.
Now what we're doing is we're flexing the Sentinel device. You can see it up on and near the arch.
My job actually is just to stay out of the way.
Pull up a little.
Yeah.
Just see that. Wonder if that's vertebral. You want to come back?
The pig
Yeah.
back.
Yeah, I'm not convinced that's not vertebral.
How's that?
So they're seeking to find the carotid orifice. This case, a little bit of tortuosity. So there you go.
That's better.
Yep.
Okay.
All right. So
More better.
engaging the carotid. Again,
so now-
this
now we-
part of the procedure in many cases can take much longer. I think that took what,
A
2
couple
minutes?
minutes. So we have two filters now, one in the innominate, one in the left common carotid. And now we're going to, from the left femoral artery, we're going to cross the aortic valve. We use a straight wire to kind of find the orifice. It can take a minute or two.
One of the things that that helps reduce stroke is minimal manipulation in the root. And what we found here is the jet, because you should see the wire flicking when you're in the jet, and then it's just a matter of timing. Just get it when the valve's open.
Able to switch to the
Okay.
hemodynamic screen so you can see.
There's our on the screen. You can see. Actually, you don't see our screen. There's another screen. Can you show the other screen or not? With the hemodynamics, or not? There's a roughly 30 millimeter gradient.
Okay.
That it? Yeah, there it is. Okay, so that's left ventricular pressure and femoral artery pressure or aortic pressure, and roughly a 30 millimeter gradient.
36, enrolled in the progress study.
Approved.
It shows you how
right.
imaging is better because we found 4 meters per second. They're only seeing much less.
Yeah.
Yeah. Jaffer's just being a comedian.
Oh, our machine is better.
Right. Go for it, George.
So I want to point out one very subtle thing from my perspective is that I somehow convinced Jaffer to join with me that we would switch from the right side to the left side access. And the whole point of that, besides having better access, was that I get to participate in the valve deployment.
Oh yeah.
Okay, so now this is the wire that it's a pre-shaped wire that we're using. Sits at the LV apex. And okay.
It looks like you're using a confida wire, right?
Confida wire, correct.
Confida.
Yeah.
Yeah, and you're
Hang on
gonna
one second. Let me just-
shave the back. When you paste from the LV wire with the confida, you shave the back a little bit, remove the coating, or you don't do that anymore.
Not really.
This wire has actually a denuded portion
It's-
that is specifically designed for that purpose.
It improves thresholds a bit, but we just paste with max juice
Mhm.
and
You ready?
for a short
Yeah.
period, so it works all right.
I got that.
And how do you
got wire?
ground?
Yep.
How do you
No,
ground
I got wire.
Okay.
the needle in the groin?
We'll
or-
show you in a minute. Yeah, we'll just show you in a second.
I got wire.
I'm gonna be patient.
And can you tell us about the safety check you did on the valve?
You want to do that?
Looking at it under
You wanna do it again,
fluoroscopy.
or-
Yeah. Just show them that.
Yeah. So we'll do it again.
I've got a wire in the needle.
Yeah.
I've got a.
So we
Can I have a short J wire?
You want to put it,
where am I?
put it in the Venus?
Yeah.
Sorry.
So in answer to your question,
There
so
we go.
while George is showing you the safety check,
So what we're looking for here is we want to make sure that the valve is smoothly loaded and that there's no infolding of tissue. And if we see that, I'll send this again. I mean, this looks great, so you don't see anything, but right. So you don't want it to go past the third node. Is that a fair fourth? Third or fourth, yep. If there was a line that was present.
right?
Watch out, you're bleeding a little bit.
Yeah, I got it.
So Philippe, in answer to your question, I think it was Philippe that asked, how do we ground? We just put a wire right here through the venous sheath. We don't always get a venous sheath. Today we just got one. We kind of look at the length of the membranous septum. If that's large, we sometimes don't bother with the venous sheath. But this is the best, gives you the lowest thresholds. Otherwise, just put a needle through the skin or the incision that we make for the TAVR sheath. You can just clip the alligator clips right on there. So 3 ways to ground. You can also just pin it to the sentinel wire. You could ground anyway. It doesn't make a big difference.
Okay. All right. Good.
Okay, do you want to go LAO?
You want to test pacing?
Sure.
One of the things with Evolute valve implantation is, so to test that, we need the wire fully sheathed to test pacing. But one of the things with Evolute valve implantation is, two advances. One, we try and aim for commissural alignment. So in LAO, I want the hat marker to the outer side, and that corresponds with a 3 o'clock position of this hub right here at the back. So we can go up.
I'm gonna go. Hang on one second.
And then we isolate the non-cusp for deployment, called a cusp overlap view. And it works well for Evolute deployment.
Okay.
And it probably reduces, it has been instrumental in trying to reduce the pacemaker rate. All right, so
George.
you can go ahead and test the
George.
pacer now.
The you can stay at 120 after you test it.
Okay.
So the pacer is capturing.
Yeah.
Can we see the screen with the hemodynamic and the pacing? Would be great.
Oh yeah,
you put
could we
full-
put
the,
hemos and pacing up on screen?
there
That'd
it
be
is.
Great. Okay.
Do you want to point out where
Top-
the hat is at the? You know, I don't think that the audience.
Not,
Or what
Can you
they're
mag up,
looking at.
George?
yeah. So the nice thing about the FX is you've got these 3 dot markers on the valve. As George and Newell unsheath, you want to keep those dot markers at the annulus. And in
Looks good right now.
it looks very good.
So we're going to do a quick shot here.
That's great.
Yeah, maybe you'll come back a little bit. It's like, oh, really? Well, I think so. Okay.
So sheath is being pulled back, and you can see the evolute valve, which is self-expanding, beginning to expand.
Okay. You can stop pacing. We'll do another shot. Huh? Yeah.
By the way, in this view, the other thing about commissural alignment, 2 of the dots are on the left-hand side, 1 on the right. And that proves we've achieved perfect commissural alignment, which is really important for re-engaging the coronaries in evolute. Probably good for flow dynamics in the sinus and reducing leaflet thrombosis as well.
So that shot proves that the valve is in a good position on the right-hand side of the screen at the left coronary sinus, and the valve is below the annulus. So I think we're ready to let it go.
All right, let's fluoro now just to see where we are. Okay. Does everybody agree?
So George just pulled the wire back to prevent that backward pressure on the valve.
Do you want to go?
And we're in LAO. We're in LAO already. And the second shot was in LAO to look at the position on the left.
I think we're okay.
Newell is keeping forward pressure. George has pulled the wire back
Okay.
and deployment.
We're pulling the sheath back, and you'll see it spring open in a second. No, it's off. I think it's off both.
I'm not sure. Now it is. Straighten the wire.
Yeah. Okay. Okay. All right. So now we're going to take a valves deployed. No going back. Yeah. Oh, okay. Want this one? Or we can do both. Shot with 10. So there's probably 2+ aortic insufficiencies. So the ventricle is filling. My vote would be just take a 20 balloon and just make it a little better and call it a day. Is that okay?
And you can see actually, so on the left-hand side, we're still in LAO, so the left cusp is isolated on the left. You see that big chunk of calcium that you saw on CT. That's where the PVL is as well. And so that's what we're trying to
Looks
address.
nastier here than it did even on CT.
Yeah, it's pretty bad.
So we may not be able to beat that, but we'll bump it out a little bit.
A little bit. All right.
Also, the skirt of this valve expands with time. So, you know, this will just get better.
I think at 91 years old,
The wire.
in northern New
Exactly.
Jersey, we'll leave it alone like that. I mean,
Yeah, yeah,
30 days,
fair
you can always come back.
yeah.
You can play double tennis now.
We're always looking for perfection.
No, not perfection. Good.
So what we just did there was we took the valve out, we put a sheath in because the evolute has an inline sheath. It doesn't go through its own sheath. It goes in on its own. So we put our 14 French sheath back, bang up with the balloon.
Okay.
Okay.
Want to pace at 180?
1 second. Clip this back on here.
No. So we're inflating that did a little bit. Okay. You can stop.
Just to your point, Philippe, this is pretty gentle. You know, the diameter from the edge of the calcium to the opposite end of the annulus was 23. So so 20 is pretty gentle in this 90-year-old.
Okay. So we'll do another shot.
We're very gentle in proximal Long Island.
Better.
Wah, wah, wee, wah.
That's a win. Okay, so there's just trace AI. Perfect.
So,
So first thing, we're going to take the sentinel out.
well, I want to just comment on the pacing technique. The thing that makes me nervous about putting that wire in the venous sheath is we lose track of it. I've already taken it out so we don't lose it upstream.
Vacuum trips. Well, the sentinel is out. You'll tell Judy, you tell us if there's anything in there.
All right.
Just the one, just Flora. Sorry.
Any questions from the audience?
Can you hear us?
We can. Everybody's so impressed there's no questions.
We're just speechless.
We're speechless.
Oh,
Let me have it.
oh, stop.
You know, one of the reasons to show this case, you know, we were discussing what to show. We showed you an incredibly complex case this morning, but one of the reasons to show this is how far aortic valve replacement has come and how easy and quickly you can replace an aortic valve in 2023. So I think
You want to give protamine?
I think we achieved that.
Yeah,
We're wondering what you're going to do for the next 20 minutes.
you guys get to go have coffee.
We're going to drink heavily.
I'm going to go visit our first patient, make sure she's okay.
Ellen, we all said hello.
Okay.
Thank you.
All right, guys. Thank you.
Thank you. Does anybody have any questions?
I will say maybe one thing. I think for this patient above 90 years old, a lot of time we use a dry seal. It was proposed on the initial slide, tortuous vessel. We like to put a 18 French or a 22 for the 34 with Evolute because it's make everything easier, neater, and especially if you have to do a BAV like that. But yep.
We do that sometimes too, depending on the situation, the tortuosity, and if we expect there's going to be changes or sheath changes. But I think there, Dr. Khan's example was good, that this is kind of like the bread and butter stuff. So we wanted everybody to see a case that wasn't a super complex one, but more like if you have a 91-year-old you're taking care of who plays tennis and doesn't want to have their chest opened, they can come in and they prepared for 10 minutes maybe before we went on. And then we were just with them for less than 20 minutes or so. So, and that was slow because they were talking about it. So it shows how well we can take care of people quickly in proximal Long Island or northern New Jersey and get them back outside.
I actually have a question.
Yeah.
You were probably involved in the planning for this this case. Tell me about valve selection, Evolute versus a sapien valve.
So when we see something like this where this patient had a very large amount of annular calcium, the one thing we don't want to do is balloon the valve initially. We really don't want to balloon the valve at all, which is why they chose a 20, which kind of just like kissed the edges of the valve and didn't do much. But going with the balloon expandable valve and somebody like this who is at 91, if he does suffer a complication like a root rupture or something like that, his chance of having that repaired successfully and doing well is not great. But a self-expanding valve here fits his size. We looked at his coronaries. We know what his coronary anatomy looks like and his need for intervention, if anything, in the future, which is very low. And so a self-expanding valve is kind of perfect for him.
And before we go to David, but I think here is important. 91 bypass protected, corner super high, so that I mean, I think if there's one place to use a self-expandable valve, it's in this guy, calcium, old patient, and protected. Okay.
So my question has to do with the MR. It went by fast, but he had 3+ MR. You know, again, he's 91. But I'd like to hear from the surgeons and from Omar. What do you think is going to happen to that MR? Do you think we're going to need to come back and do something about that? What would you have done if he was, you know, instead of 91, been 71?
Well, I mean, a 91-year-old with truly severe AS with a very high gradient, who's going for an open operation, most likely he would just get an aortic valve replacement, and then we would presume that there'd be a significant downgrade of his MR after, you know, relieving the LVOT obstruction. Obviously, if he has structural valve deterioration, primary MR, that's a different story, but presumably this was all functional, secondary to the high transvalvular gradient. So even in the OR, my bias would be not to touch the mitral valve in this guy. Yeah.
Would you have done it any differently with 71? And, you know, again, I mean, or just functional, you leave it alone, is the mantra.
Well,
I'm making it tough on purpose.
I think it depends on what the valve looks like and what's going on. We see plenty of people that have some degree of MR, but very severe AS. And when you relieve that pressure, the pressure in the LV goes down. So if their LV pressure is 180, but their systemic pressure is 120, there's 60 extra millimeters in there that are pushing against the mitral valve every time the heart contracts. So we often see the MR go down anyway. In a 91-year-old, the STS calculator doesn't allow us to put multiple procedures other than an AVR cabbage or a mitral cab. It doesn't allow for double valve. So we can only infer what would happen or extrapolate what would happen, I guess, based on, you know, a 91-year-old going in for a double valve operation would make him a lot higher risk.
You ever do an Alfieri in these cases?
I mean, Alfieri is pretty much in the preserve of Dr. Chung and Dr. Berkey these days.
But if you're there, I mean, if you're like,
well, I mean, you know, for me, I think a quick mitral ring in a younger, low-risk patient would be an easy thing to do with not much downside, and that would probably be my bias if I felt that they had enough MR to justify doing a double valve procedure.
Plus, you know, after the aortic valve is treated, either way, the patient's going to likely be on more medication. So that may, you know, help with some of the mitral.
Omar, do you have any thoughts about the MR improving?
Yeah, so I think, I mean, we didn't see the echo images, but it said eccentric jet, which could mean functional or degenerative. And similarly to in surgery, we have TAVR data saying that functional MR likely gets better, but degenerative doesn't. So I think that's something you could assess later. And Al and I have had discussions in the OR when he's doing an AVR of a combined strategy. So for example, if he thinks the risk of an additional mitral surgery is high, even in a youngish patient, we're calling 70 young, that patient could then be reevaluated later for a
clip,
potential mitral clip.
Great.
Yeah, I think it's an important point. I mean, it's good to have a plan of, you know, what to do with the mitral, even after you treat the aortic. You know, the patient had a TEE, a CTA, so you probably could get a good sense if, you know, you could treat it with a TEER mitral clip or TMVR.
Yeah. A lot of patients do really well afterwards, and they don't need the mitral treated, so we would watch.
Yeah, I would guess, too, the description of this guy's symptoms were dyspnea on exertion. He wasn't having ankle edema. He wasn't having orthopnea. My guess is that it's AS is his primary problem. Always, yeah.
Yep.